The effectiveness of HSCT in aggressive multiple sclerosis is supported by several reports which are mainly focused on the use of cyclophosphamide-based conditioning regimens. In this study, we report long-term outcomes of people with relapsing multiple sclerosis, primary progressive MS excluded, who were treated in Florence over a 25-year period, adopting BIM-ATG as a conditioning regimen. 110 patients were included in the safety cohort. TRM was 0.9%, and 24% of the cases experienced viral reactivations requiring treatment. As for long-term adverse events, we had one casualty due to glioblastoma, and 2 further neoplasms were diagnosed over follow-up. The rate of secondary autoimmunity was roughly 10%. Neurological outcomes were available for 93 patients, 50 relapsing-remitting, and 43 secondary progressive MS. Median follow-up after HSCT was of 5 years, reaching up to almost 22 years. Progression-free survival and survival-free from clinical and radiological disease activity, which is NIDA-free, were 69 and 68% at year 5 in the cohort, and both were higher in relapsing-remitting compared to secondary progressive MS patients, being of roughly 90% versus 48% at year 5, respectively. New focal inflammatory events were extremely rare, and we reported only 6 events over 575 patient years of follow-up. So, as expected, the main reason for NIDA failure was EDSS progression, mostly in the progressive cohort. 16 patients were followed up for more than 10 years after HSCT for a median of 15 years. These patients included 12 secondary progressive and 4 relapsing-remitting MS. Progression-free survival at year 10 was 100% in relapsing-remitting and 27% in secondary progressive MS. When looking into predictors of treatment response, we couldn't really find anything really clinically meaningful, as only the MS phenotype, progressive phenotype, was associated with EDSS progression after HSCT. So in conclusion, our results further support the use of HSCT in relapsing-remitting multiple sclerosis. Nonetheless, that might still be place for HSCT in progressive disease. And if disability progression is due to inflammation compartmentalized within the CNS, and if HSCT can actually act on this compartment, then we eagerly need biomarkers of this phenomenon that could assist us in treatment decision-making.